And now we will move on to Dr. Namrata Madam's talk. And I know she doesn't require any introduction, but let me give her present before you in a nutshell. Dr. Namrata Sharma, the current professor at All India Institute of Medical Sciences, did her fellowship from Moorfields Eye Hospital, London. And she is the first Indian to be introduced as the Director at Large International Member in the Cornea Society International of USA. And she got many accolades, many papers, many awards, and it's difficult to compile in a very short time. And her publications are amounting to 691 publications in international peer-reviewed journals, has authorized 19 books and instruction courses at our several international and national platforms. And she is currently the scientific committee chairperson of All India of AIOs and the treasurer of Asia Pacific Academy of Ophthalmology. And it is my privilege to have Madam kindly consented to give a talk on fungal keratitis, the management algorithm. Over to you, ma'am.
Thank you, Anita. It's always a pleasure and privilege to be here in Kerala. And thank you. Whenever I have done sessions in Kerala, I've always been a part of Anita's instruction course. So thank you for your kindness. I'll be talking to you about management keratitis, management algorithm of fungal keratitis, which we've been working on for over now last 10 years. And this is just a gist of what we have learned from that. There are no financial disclosures, and I think it is very important to know geographically where you are located when you are managing any microbial keratitis. So if you're in South India, I am told it is Fusarium which is the commonest. If you're in North India, it is the Aspergillus which is the commonest. So I think that is something that you have to keep in mind. Then diagnosis is not so much of a difficulty by clinical looking. It is dry, it is feathery margins, satellite lesions, endothelial plaques, fixed hypopyon. Sometimes dementatious keratitis has a pigmentation like this, and your fellow says it's iris prolapse. It's not iris prolapse, it's pigmentation. When you treat it, becomes like this, and you need to diagnose it first. And I think the most important stain in a case of microbial keratitis is KOH. So you do KOH, and once you know that the hyphae are not there, you can be absolutely sure that you don't have to start antifungal. But if they are there, you have to start the antifungal agent. And you have to send again the scrapings for culture on Sebrot's dextrose agar. Suppose you think it is fungal, but your microbiology doesn't support you. You can still do confocal microscopy if that is available, and also can do PCR because that becomes positive in 74% of the cases. We've done studies to look at the anterior segment OCT of the fungal keratitis, and you can actually see the infiltrate size, epithelial defect, posterior abscess, areas of necrosis, as well as cystic spaces, and also monitor the activity. This is one new tool that we are looking at, how to monitor fungal keratitis, especially the posterior abscess. Now, the mainstay for whatever fungal keratitis it is, whether it is Aspergillus or Fusarium, is 5% netamycin, which is given early during the daytime, too early at the bedtime, and if there is worsening, you add another drug. And therapy for fungal keratitis would take about 3 to 4 weeks, unlike a bacterial keratitis, which would heal in about 8 to 10 days. So simple cases, Fusarium keratitis, gave topical netamycin, healed. But there are some limitations of topical netamycin, and that is it doesn't have a very good penetration and it has a poor bioavailability. So the MUT1 trial, that is the mycotic ulcer treatment trial, did teach us that voriconazole you should never start as a monotherapy. Systemic drugs have a role to play in large ulcers, severe deep keratitis, scleritis, post PK keratitis, and endophthalmitis. And we like to give ketoconazole, itraconazole, or voriconazole, or fluconazole. And except for I, which is 100 mg BD, all the others are 200 mg BD, so it is easy to remember that. LFT has to be done after every 2 weeks. So this is a large ulcer. Topical netamycin with systemic was given due to Fusarium, and finally a scar is formed. Of course, you need to do a penetrating keratoplasty at a later date for this. This was a tunnel infection due to Fusarium keratitis, and again this healed on voriconazole. MUD2 trial again did teach us that Fusarium keratitis may benefit by the addition of oral voriconazole to topical natamycin. So we did a comparative study which oral drug was better, voriconazole or ketoconazole. So we found that clinically both did better. There was no difference clinically between the two. But when we looked at the concentration in the tear film, we found that voriconazole was far more in tear film as compared to ketoconazole. So for all your patients who can afford systemic voriconazole, start that. But if they can't afford, you can give systemic ketoconazole because that will also have equally good results. So just to show results from those studies. Now sometimes what happens, both these things don't work. Then what do? You do targeted drug delivery, which could be intracameral injections or intrastromal injections. And intracameral injections you would give for large ulcers like this with hypopion, endothelial exudates, deep anterior chamber exudates. And you can either give amphotericin B 5 to 7.5 microgram per 0.1 ml or voriconazole 50 to 100 microgram per 0.1 ml. Large hypopion resolved on intracameral amphotericin B. Of course, the topical medications have to continue. Again, you can give intrastromal injections, that means into the stroma, for deep mycotic keratitis which are not perforated and which are not responsive to your topical and systemic therapy. These were our first cases. This in fact was going for therapeutic keratoplasty. Then we thought let's try intrastromal if it works or not, and the results were good. So we didn't have to do a therapeutic graft. We can directly do a optical graft. Patient was saved of 2 grafts. So we thought this was a good tool in our armamentarium. This was a study which was again a randomized control trial where we looked at the role of intrastromal injections, and we found that they did well. And we also thought that maybe they cause more vascularization, but we found that they did not cause so much of vascularization, and the vascularization was comparable whether you gave the intrastromal injections or not. Now this is how to actually give these drugs. So you have this keratitis here and you have exudates. So make a MVR incision just like you do for your phacoemulsification. Wash out the exudates first because they are impeding the penetration of the drug that you will give. Give intracameral voriconazole 50 microgram per 0.1 ml, and then give intrastromal injections from the area which is non-thinned out, from the area which is relatively clear into 5 to 6 hemimeridians surrounding the lesion. And what is your endpoint? Something like a phacohydration wound that you do. So that is your endpoint. So these are simple to give. Again, we came out at what we call as the TST protocol, or the topical systemic targeted therapy protocol for fungal keratitis. And this was based on 223 studies, which were 223 cases which were followed up prospectively. And this is what it is. So if your ulcer size is less than 5 millimeters with less than 5 millimeters stroma involvement, give topical natamycin alone. If the response is good, your ulcer is healed. If it is not good, you add another drug which could be amphotericin B or voriconazole. But if the ulcer size is large, the ulcer depth is more than 5 and 50% involvement, then start topical and systemic both. So you will give topical natamycin and systemic antifungal both. If for 2 weeks there is no response, add topical voriconazole, that means a second drug. And if there is no response after 4 weeks, give intrastromal, intracameral, or both depending upon where your exudates are. This is something that we've been working on. Natamycin is a suspension, whitish, like this. But if we've in RP Center Ocular Pharmacy, we have linked it to a polymer so that it becomes soluble like this. So its penetration would increase much more, and we've patented this Netasol. We found that the levels of Netasol are also higher and it stays for a prolonged period of time. So again, these are publications of the same, and then we compared topical monotherapy of natamycin 5% with Netasol 1%, as well as the natamycin and the voriconazole therapy, and we found that the results are best with Netasol, followed by natamycin and voriconazole, and then natamycin. Of course, this has to be commercially available. Then we also compared the intrastromal injections of these drugs, which was amphotericin B, Netasol, and voriconazole. And again, we found netasol was the best, followed by voriconazole, followed by amphotericin B. So these are some of the results of intrastromal netasol where the ulcers have healed. Large ulcer which responded to intrastromal netasol, another one which responded to intrastromal voriconazole, and this is a very huge ulcer responded to intrastromal voriconazole, now awaiting penetrating keratoplasty. Some of the posterior abscesses responded again to intrastromal injections, and this is just to show the comparison. So what is the difference? With amphotericin B, you will have a little more vascularization as compared to with natamycin or with voriconazole. So these are our review articles which are published in Survey of Ophthalmology if you want to know the details. And of course, I think fungal keratitis has no role at all, which was proven by our study as well as the studies which were done in Arvind Eye Hospital. And of course, if everything fails, then one has to do therapeutic keratoplasty. And again, our review article on therapeutic keratoplasty in Current Opinions of Ophthalmology. So this is the conclusion part, and that is the bugs, the microbes are smarter than all of us. So when one tool does not work, you have to use multiple tools. So a fungal keratitis, therapeutic keratoplasty done, recurrence again, intrastromal injections given at the graft-host junction, so resolving. So we may think we know it all, but the microorganisms are very adaptable. Again, our review article in Ocular Surface, this is the latest one on fungal keratitis, and this is how it should heal. Stain every time when the fungal keratitis or any keratitis comes so that it becomes a faint scar, and document it, of course, and does not go into a sequel like this. So I would like to invite all of you to Jaipur, if you have not blocked your dates, 12th to 15th March 2026, AIOC or annual conference. And I humbly would like to request you to please support me for Chairman Scientific Committee in AIOS election 2026. Thank you very much for your kind attention.
Anil or
So, if I have done a therapeutic keratoplasty for fungal keratitis, I would not start. I now like to start cyclosporin immediately on day 1, Sequa to be more precise, because that acts faster. And then after say 2 weeks or 2 to 3 weeks, provided epithelialization has occurred, provided there is no recurrence, I would start topical steroids.
that is the institutional protocol, and it is individualized, I think, no ma'am?
Yeah, some people would start 4 weeks later, but I would.
We start 2 weeks. In
2
the
weeks,
NP,
yeah,
it
2
is
weeks.
started 2 weeks. And what about the role of oral cyclosporin, ma'am, in the large giant papillae in allergic conjunctivitis? So you usually will you give
So for very
children? And
for very recalcitrant cases, I would give oral cyclosporin, short course, because that breaks the vicious cycle. That is the only idea, because otherwise they are so resistant. I don't know, Dr. Anil would think otherwise. I don't know when.
No, I have no experience with using oral like this
Oral.
one.
So
But
for
tacrolimus I have used, ma'am.
for very recalcitrant cases, we can start oral cyclosporin. And sometimes it miraculously will stop at least the inflammatory cycle.
Oral tacrolimus, actually, now previously the problem was the cost of tacrolimus, which is very expensive. Now it is almost the same. So I think the side effect profile is slightly better with the tacrolimus.